Okay, you guys can see and hear me well?
Yep.
Okay, we'll try to make this quick. I know this is the last talk of the day. We'll try to make it interesting. I thought it was interesting. Today, we're going to talk about the busy ED in the face of the law. So let me just take my face out of my screen. Okay, there. Okay, so Saturday evening, you start your shift with a great mood. You look at the board and you ask yourself what kind of shift you're going to get. Okay, so this is what you see. You tell yourself, okay, that's great. I still have a stretcher. There's hope. So then you look at the waiting room. Hopefully that's going to be better. And this is what you see. Then that's how you feel. So your great mood is gone and you're telling yourself you're going to have a hell of a shift and your shift hasn't started yet and you're already waiting for your colleague to come in saving the day, obviously in the shape of a woman. During that shift, you screw up. You make a mistake. And your worst fear comes true. You get sued. So this is all to introduce the topic for medical responsibility. This is an important disclaimer. As you all know, if I'm here, it's because I am not a lawyer in practice. So if you guys have questions, it's possible I don't have the specific answer for, but I'll go and look for it. That's the only thing I can do. So will the judge consider this absolute craziness while deciding if you've actually committed a fault? So that was the main research question. Does the context of practice or situation in which a mistake is made matter when determining medical responsibility? Is there a fault in that case? Here's a brief outline of the presentation. We're going to do a very, very brief review of the Quebec judicial system, just so you have an overview of what's happening. I want to make it clear what the distinction between criminal, civil, and administrative law is. We'll review quickly your duties as a physician. What are your duties? What are the 3 pillars of medical responsibility? And finally, does context matter in all these different fields of law? Quick review of Quebec judicial system. So the only thing I want you to get from that is that you have different courts that do different things and are there for different purposes. You may be brought into a different court depending on what the fault is. Here's the money slide. So criminal law, disciplinary law, and civil law. What does that change and why should you care? Let's start with criminal law. Criminal law, you really screwed up. So the Crown prosecutor reviewed the file, reviewed the charges, and decided to press charges against you. The burden of proof for that is beyond all reasonable doubt. Why is that? Because the endpoint is jail versus no jail or time in community. So the stake is really high. So the burden of proof is really high. In medicine, if we're talking about liability while you're acting as a doctor, the main things you're going to see are manslaughter or gross negligence causing death. The later one being the most common. Disciplinary law. Now, you know what? No, let's start with civil law. Then you must prove 3 things: fault, prejudice, and a causality between both. The endpoint is getting money, what they called in law damages and interest. So this is when we think about USA and how we hear like the outraged sum of money that some people are getting from doctors. Here I'll reassure you it's much less. The burden of proof is 50% plus 1. Disciplinary law is something that's in between these 2 things. So this is where the CMC and the Board of Discipline will sit and decide whether or not your actions were in accordance with the law governing your profession. In this case, we're talking about your code of conduct, mainly. What is the endpoint of that? Restricting your license, removing your license, giving you a fine. There's different things that can be done. And all of these things go into a publication, into a journal. So they account for a bit of shame, let's face it. What I want you to understand is that these 3 things are very distinct thing, and that a patient or an altercation with a patient could actually result in you being brought in all of these courts. So these are not mutually exclusive. They can all happen. So let's look at criminal law first. How you may ask yourself, is that common that a doctor goes into in front of a criminal court? This should tell you two things. First, for the non-French speaker, this says a first doctor guilty of criminal charges in Canada. He discharged a patient who was found dead a few hours later. So this should tell you two things. First, it should tell you that it's very, very rare that this happens. So it should make you safe. The other thing is that you should not read the Journal de Montréal because they're a bunch of liars. This is actually the second doctor in Canada who was found guilty. So we're going to review these two cases. First, what is gross negligence? Everyone is criminally negligent who, in doing anything or in omitting to do anything that is his duty to do, shows wanton or reckless disregard for the lives or safety of others. That has to happen when there is actually a duty imposed by law for you to act, which is the case when you see a patient, right? Gross negligence, the fault element, has to be a marked and substantial departure from what a reasonable person would do in the circumstances. It is done by measuring the degree to which the accused's conduct departed from that of a reasonable person in the circumstances. So let's look at what happened with Dr. Dufour. The facts: night shift, patient was seen at midnight, then at 6:30. Patient was there for rest distress, was known for MPOC, hypertension, and alcoholism. That patient had asked to leave 4 times during the night. On the triage note, she was noted to be slightly tacky, to have evidence of substernal tirage, and use of accessory muscle. Triage note specifically says, don't let the patient go without talking to the family. Following his second evaluation, Dr. Dufour discharged the victim, well, the patient, after she went to smoke to the toilet with her oxygen on. So without giving her information as to why she should stay, he just said, fine, just go, leave the ER. The patient died 3 hours later. There was no signed declaration of leaving AMA in the chart. What was his defense? I was the only ER doctor in the night shift. 33 patients came to the ER. 12 ambulances, not even counting the patient who were a stretcher, who counted for about 50 patients. What did his note say? What was the discharge? Let's see. Patient went smoking to the bathroom, discharged. I'm not going to do a polling on that, but I'm pretty sure everybody can say that that's not enough information. So he was accused of criminal negligence, but after negotiation with the crown, he pleaded guilty to a different charge. I'm telling you that for honesty, but basically it doesn't change anything. He was, for the purpose of this discussion, we have to consider this was criminal negligence. This was done so that the imprisonment could actually be purged in the community. So it's a legal technicality. Let's consider it criminal negligence. He pled guilty and recognized that he shouldn't have discharged her and that she should have signed a waiver saying she was leaving AMA. So the granting of the discharge was deemed as an untimely act. Result? He was sentenced to 9 months conditional sentence. So that was an imprisonment to be purged in the community. So this guy, Dr. Dufour, underwent a trial as well in disciplinary law. Here's what the CMQ had to say. He was negligent in omitting the sign of rest distress objectified by the nursing staff. He was negligent in not asking for an EKG, not asking for trope, in ignoring the tachy, in ignoring the blood result that showed an elevated white blood cell count that could sign a possible infection. He was negligent in not not writing a note properly. He was also negligent in lying during the enquête. These are extracted from judgment. We'll skip this. So did context matter here? Yes, but to a certain extent. A busy ED is not an excuse to be grossly negligent. So that's a time to touch on the difference between action and omission. There's a difference between being very busy and not having time to see a patient versus discharging inappropriately a patient. So it's reasonable to assume that the story would have been different for Dr. Dufour if, because of the busy ED, the patient would not have been seen in a timely manner. Of note here, since he pleaded guilty and the sanction was the result of a commune suggestion, it is not really known what importance to the context the judge would have given in deciding whether or not he was guilty of criminal charges. Let's look at the other doctrine, the whole history of in the whole last 120 years that was found guilty. So in this case, it was an anesthetic who had a patient of 17 years old who was operated for a broken leg. He intubated the patient, and in plugging the patient to the monitor, used only 2 out of the 4 safety checks that could be used. And that was it. So the nurse asked him to put it on, and he said it was not necessary. So what happened is that the anesthetist left the room, as they often do, and he just said to the nurse, "I'm leaving." He didn't give any instruction. While he was away, the patient became disconnected from the vent, and that 17-year-old patient remained mainly brain dead afterwards, because nobody noticed that it was disconnected, and he was deprived of oxygen too long. So the anesthetic not only did that, but he also lied when they did the inquiry, and he lied to the family, saying if he was not in the room, he always had the patient inside, and that was simply not true. Result: 6 months of prison. So this article is really interesting because it's a review of what happened in the criminalization of medical mistake in Canada in the last in between 1900 and 207. So during that time, because Dr. Dufour in 2018, there was only 1 out of 15 patients who was found actually guilty. 15 patients, only 15 physicians were actually charged with criminal negligence and 1 with manslaughter. So very not common. This is just for fun. I thought it was interesting to see that in 1935, it was not deemed to be criminal to examine a patient drunk twice. So in this case, I rest my case. 1 out of the 15 physicians in Canada who faced serious criminal charges as a result negligence, only 1 was convicted, which brings it to a conviction rate of 6.6%. Sorry. So whether or not context matters to such a busy ED, let's just settle for the fact that you're really unlikely to be faced with the situation. The reality is that the case base, as I've proven, is not sufficient to draw a definite conclusion. But by the nature of what we know with criminal law, it is very likely would be considered, at the very least, by the Crown prosecutor while deciding to press charges against you or not. The thing is that once you're so far across the line to be charged with gross negligence, it is less likely to save you and to be a determining factor, but would still be taken into consideration, in my opinion. Now, let's look at the question under civil law. As I said before, civil law is simple. And this is what I want you to grasp really clearly, because if you get a mise en demeure and you get sued, this will help you evaluate whether that complaint has a good chance of succeeding or not. Is there a fault? Is there an actual prejudice to the patient? And is there a causality in between both? This has to happen when there's actually a duty of care between you and the patient. This is a whole Pandora box, which I am not willing to open today, might be a subject to another presentation. What are your duties as a physician now? You have to make a diagnosis. You have to advise the patient of it. You have to properly treat your patient, which including proper referral and asking for consults. And you have to ensure proper follow-up and respect confidentiality. That's it. See, medicine is easy after all. What is the intensity of those duties? Result versus means. Result is you buying a plane to Thailand. The carrier has to bring you from point A to point B, and that is their obligation that they have under all circumstances to fill. Obligation of means is most of the time you and your patient. It can be summed up as you doing the best you can with what you've got. Why is that? Because we don't want a patient suing you because you were not successful in curing his cancer. Actually, the Code of Ethics even prohibits you to make such a premise. A physician must refrain from guaranteeing, explicitly or implicitly, the effectiveness of an examination, investigation, or treatment or the cure of a disease. But as in law, there's always an exception. So when do you have an obligation of result? The fact of operating on the right leg, of respecting confidentiality, to write legible prescription. These are all cases where you actually have to succeed and there's just no excuses. But most of the times you're in the domain of the obligation of means. What is a mistake versus a fault? What really differentiates them is the fact of having, in the therapeutic process, really deviated from the rules of art, from what good professional practice is, and from what another doctor would have done. Here's some jurisprudence just to illustrate what is a mistake. Vigneault contre Mathieu, a doctor sectioning by mistake the femoral vein in context of a procedure for varices, was deemed to use all possible means to avoid it, not responsible. Dubois contre Go, a GP diagnosed a finger sprain instead of an actual rupture of the flexor tendon. He was exonerated. Tremblay contre Claveau, two doctors did a diagnosis of viremia instead of meningitis, and they were deemed not responsible because he was a third physician thinking this was not meningitis. Amel contre Haché, this one is interesting. Misdiagnosed an ectopic pregnancy for an incomplete abortion. In this case, no ultrasound was done. Let's just focus on the fact that it was 1994, so that the decision would definitely not be the same today. But in that context, here the patient completely refused any transfer to have the ultrasound done. So 14 days later, she was re-hospitalized and a laparotomy was done where the ectopic pregnancy was seen. The main contention of the patient was there was a mistake in the primary diagnosis. But the court basically said, listen, it's not the doctor's fault, it's yours, you refused to transfer. So here are a few things that we know the tribunal will take into consideration. Hôpital Général de la Région de l'Amiens contre Perron. As a general rule, the obligation of a physician and hospital toward a patient is one of means. The obligation of prudence and diligence will not be subjectively assessed. It will be done by rather according to an objective and abstract criterion, under which the court asks what another doctor, another specialist, another nurse of ordinary and reasonable knowledge, competence, and skills would have done under the circumstances, similar to those in which the person whose conduct is to be judged. That will be how people decide, how the judge decide whether or not you committed a fault. So would a reasonable physician having similar education and training would have done the same thing? In Hôpital Général de la Région de l'Amiens, the court state, and it's really there in all the case law, courts must be careful not to rely on the perfect vision afforded by hindsight. Meaning it's way easier to judge a situation after everything happened than when we actually made it to this situation. What's the burden of proof? That's actually a bit interesting because it doesn't play in our favor. The courts have found that it was unfair to have the patient, given the complexity of the medical system and of the subject, it was unfair to have them have the burden of proof to proving the fault. So most of the time, there's caveats to that, but most of the time, you will have to be the one proving there was no fault. What's your defense? You acted as a reasonable doctor and somebody else would have done the same thing. What about context now? We're still in civil law talking about context. It is clear that it's taken into consideration, but its impact is evaluated on a case-to-case matter, and it will depend on a multitude of factors. So we'll review a few case law that I found useful. Brochu contre Camden-Bourgault. What comes out of that is that it is clear that the resources at your disposition will be taken into consideration. Where you practice, the consultants you have access to, the quality and disponibility of the medical technology, all of that will matter. That means that if you work in a tertiary center in Montreal and you have access to all of your consultants, context does matter, but actually not in your favor in that case, because you'll have a higher level of standard to be upheld to. So the abundance of resources available to a healthcare professional, as well as the above average quality of these resources, are factors that require the court to be more demanding on him. That being said, all events must be taken into consideration. The Quebec courts have repeatedly stressed the importance of taking into account the exact sequence of events, as well as the circumstances that may have influenced them. And one of the fundamental circumstances that must be taken into account is the emergency situation in which a health professional would have been. So let's look at a few cases. Perron contre Hôpital Général de la Région de l'Amiante. A 5-year-old child went to 2 surgeries that were considered minor. In the recovery room, he went into cardiac arrest. It was deemed to be the result of the anesthesia. What happened is there was a small delay between the urgent call to the anesthesiologist and his arrival, because he was already intubating a patient for an urgent indication. And we're in a context where there was only 2 anesthesiologists for 5 ongoing OR, and they were also covering all obstetrics. The main issue here was that there was a significant delay in calling the anesthesiologist from the nursing perspective. So when they saw that the patient was in RAS distress, it took too long for them to call the doctor. In the Superior Court, they decided that the hospital and both the anesthesiologists were responsible for the damages and interest, and $70,000 is actually a lot of money for the time. The judge of the Court of Appeal undid that decision. He took note of the shortage of anesthesiologists and the fact that they have to serve 5 wards at the time, not even counting obstetrics. He says on that, of course, the ideal is for the anesthesiologist to take care of only 1 patient at the time, but the constraints imposed by the shortage of specialists allow it to be otherwise. They are placed in a dilemma. Either they treat ideally their patient at the expense of number of patients performed, or they sacrifice a little to the ideal while respecting an admissible safety margin. So here it was deemed that if the anesthesiologist had been called sooner, the damages would have been less important. Here's where it gets really interesting for us. The anesthetic is surrounded by assistant nurses who are subject to his instruction and assist him as he deems opportune and efficient. Although they're chosen and paid by the hospital, these assistants engage in the performing of their duties, the doctor and the hospital. So in that case, both doctors were exonerated. The role of the doctor is to perform medical act of his specialty. He is responsible for the patient during all time, but the hospital provides him with health professionals who are adequately trained to provide care in the recovery room and on whom he has a right to be able to rely. So I found that was really interesting. So unless the fault is committed by acting directly under the direction and immediate control of the doctor, this is saying the doctor should not be responsible. So in that case, they took out the responsibility of the 2 doctors and had all of the damages paid by the hospital because they recognized that the fault was from the nursing staff. On the other side, Côté, contre Hôtel-Dieu de Québec. Mr. Côté hurt his knee. He goes to the OR, gets an epidural. The epidural results in him having a persistent partial paralysis of both legs. The doctor was doing 3 rooms at the same time. It was judged that Monsieur Côté, quote unquote, presented a condition making him susceptible to drop his BP. That should have been known, and a more adequate control of the BP should have been done during the OR. They found that his lack of monitoring was the cause of the damages in that case. And one of the cause of that was because he was doing 3 ORs at the same time. In the first instance, and the Court of Appeal confirmed, the doctor was found responsible for damages for accepting too heavy of a workload for a certain period of time, and for having agreed to work in the company of insufficient and unqualified staff to supervise these patients. So here's the judge saying on the Court of Appeal, The responsibility of the hospital center was also retained because it was imposed of the anesthesiologist a too heavy workload. This is the express recognition of responsibility for a fault in the organization of the anesthesia service. So that's interesting. It says basically the exact opposite of the other decision I showed you. Here it says, so it is not a fault in itself, that of accepting an overload of work. On the other hand, it does not reduce the degree of care due to each patient. The overworked doctor therefore risks placing himself in a situation of physical impossibility, which will cause damage for which he will respond. So when I read that, I felt really scared but we're going to look at more cases. What do we make of this? Lacombe contre Hospital Maisonneuve-Rosemont. Patient was feeling unwell, shortness of breath, diaphoretic, difficulty talking. Goes to ER by ambulance. At that point, on 100% nasal prong. The triage nurse says, sends the patient to stretcher, but no ring bell was given for the patient to call for help. They were sent on the stretcher in the hallway. ED is described as hellish by the triage nurse last night. Unfortunately, that patient was found dead in the hallway 3 hours later without any assessment of DMD. The brother took a legal action, claiming that the lack of monitoring of the hospital was the reason his sister was dead. They say that each hospital is responsible to provide a safe environment to patient. What's interesting here is that no doctor was mis en cause. So the doctor was not deemed responsible for that. Noël Voisard contre Centre de Santé des Services Sociaux de La Salle. Madame Voisard asked for the sum of $7,000. That's kind of funny. For the pain she had to endure in the waiting room prior to prise en charge médicale. She was in the ER for a wrist fracture. The tribunal says that, as already mentioned, even if the tribunal deplores the slowness of the system, and especially the fact that Madame had to wait several hours in an uncomfortable installed waiting room, they cannot retain fault. This was the ER staff was responding to demand given the staff it had to do in place to do so. They do an aparté on triage, saying that these waiting time, referring to triage, unfortunately, they're out of control. It appears from the Quebec sorting standards that they remain an objective to be achieved without imposing a constraint or a legal obligation for the patients to be seen in a certain amount of time. However, to the extent that Quebec hospitals are public institutions, the quantity of resources allocated to them by the government, as well as their management by hospital, are factors that can affect the quality of service received by patient, and even sometimes be linked to a prejudice. So here they're saying that the fact that the hospital is not providing enough staff may be engaging the responsibility of the doctor. However, this eventually must be taken into account when assessing the liability of a doctor or hospital center, which is also recognized by case law. So what's the conclusion of all this? In Quebec law, the courts have not adopted upon a clear position of principle as to whether or not the situation resulting from the limitation of resources in a hospital environment constitutes a mitigating or an aggravating circumstances for the liability of doctors. As some of the case law shows, and that I showed you, they're actually divided in the issue, and they in some cases contradict themselves. So all I can say for now is that the courts retain full latitude to judge on a case-to-case basis. To what extent the circumstances in which we work in will change whether there's a fault or not. But there is encouraging jurisprudence, and the case law is heading toward ourselves. What do we retain of all of this? This is a mention to glory. If a patient was not seen by you in the ER, your level of responsibility is much lessened. This is why there's a triage system in place. The nursing staff is mainly responsible for that triage system, and as the case law shows, it is okay to rely on them on that, to a certain extent, of course. Prone quality over quantity. In the context of an unclear law, what Lacombe and Hôpital Maisonneuve-Rosemont shows is that an interesting door is open. So in that case, as you may recall, the hospital was found guilty and no doctor was mis en cause. So in the context of the ever-growing problem of access to care, it's reasonable to think that the hospital will be increasingly responsible of the fault occurring within its wall. If the fault committed is done in the context of an overcrowded ED department, it really appears unfair to have the entire legal load over the shoulders of the doctor. That being said, as I said, more firm position from the court are needed. So if you take a manageable load of patient and something damageable happens to a patient that was not seen by you, it's reasonable to think you're not even going to get seen and the hospital will be. So hopefully you feel a little bit better. Third step, disciplinary law. This is the highest standard to which you will be upheld to. This is your code of ethics that has a lot of duties and obligation for you to fill. What's the link between what I said in civil law and disciplinary law? What's nice is that we can skip a lot of talking because there is a development of a strong case law and doctrinal trend to the effect that the analysis of the fault will be the same whether it's in civil law or in disciplinary law. The main difference you have to understand is that prejudice, it is not needed for you to be deemed guilty of an offense in disciplinary law. I'll give you an example. Let's say you look into your DSQ of your husband for personal reason. You think he is cheating and you want to make sure he doesn't have chlamydia. So this is for you. You're doing that for you. Under civil law, your husband or ex-husband now might have a really hard time proving that that there's actually a prejudice. In disciplinary law, there would without doubt be a fault, and you most likely would be sanctioned for looking into a DSQ of a patient you didn't have the right to, because this is confidentiality and they're really touchy on that. How would that work? Is that the CMC will hear any complaint that's lodged against you, either by the syndic after an inquiry or directly from a plaintiff, such as a patient. They'll look at the evidence, they'll look at the chart, and they'll decide whether or not they go into a hearing. If that's the case, then 2 doctors and 1 lawyer will hear you, and that'll be the board that will decide whether or not you were wrong and whether or not you should be punished. What are the possible disciplinary sanctions? Reprimand. They could just give you a slap on the wrist and say you've been bad, don't do it again. They obviously could say you're fine, there was no issue, you're not at fault. They could take your permit away. They could restrict your permit and saying, let's say now you're an ED doctor who cannot intubate. They could suspend your right to do certain activities. They could do basically all of that. They can also have and force you into non-disciplinary intervention. This could be like forcing you to go to therapy, like forcing you to go back on clinical duties with increased supervision and not being able to practice on your own for a while. So this is a gross algorithm on how a complaint would be lodged, but we're not going to go into that given time is running away. So we discussed different things. We focused on what criminal, disciplinary, and civil law could do for or against you. And we're going to conclude of that. Does context matter? To me, yes. It just depends what you're trying to use it as an excuse for. In criminal law, as I said earlier, if your conduct is so far from the line to be charged with gross negligence, it's unlikely that that the fact that your ED was overcrowded will be an excuse. It may be considered as an attenuating factor in the sentence if things goes to that. But as I said earlier, we don't have enough case law to draw a definite conclusion. In civil law, there's more and more jurisprudence recognizing the fact that the limited resources and the crowded ED are part of a reality. So it's recognized more and more that this can create a source of liability for doctors, and the case law was shown to take it into consideration. While I admit it is contradictory in some point, it is taken into consideration. So while it's not an excuse to not do your job properly, it appears they would take it into consideration. Disciplinary law, same principle of the determination of the fault applies. Once again, I'll remind you, you don't need prejudice to be guilty, and this is the highest standard you can be held to. So hopefully, once you see this and you see the crowded triage, you feel a little bit better about your responsibility. One of the last slides is how to diminish your risk of liability. Once again, quality over quantity. Your level of responsibility is low for a patient that was not seen. Once the patient is under your care, it seems to be a different story. So it's hard. It seems to be harder. That's a trend I've noted through the lectures. It seems to be harder to use that as a defense to limit your liability. At least for an action, the story might be different for an omission. So a positive act like discharging a patient while you're doing it too fast, you're still responsible whether or not the ED is overcrowded. I think it'll be very interesting to see how the jurisprudence will develop in determining the proportion of the responsibility of the hospital itself. Because as I said, the hospital have obligations as well, and they need to give up, to give up enough staff, enough room, enough things to see patients properly. If you find yourself in a difficult situation on a night shift, you're alone, and you realize that you have too much on your plate and there's not much that can be done, make sure you write that context when relevant in your note. For example, note delayed. 3 ambulances came in requiring my attention between the time this patient was seen and the labs could be ordered. Anything that is relevant to the context, write it. It might save your ass later. Give clear discharge instruction and document those. So hopefully you have gained a better understanding of the law surrounding your practice a little bit. And I just wanted to leave you on a resource of the CMQ that's really interesting. It's a service conseil that is free and that is confidential. So if you have a question on something, then you can refer to them, and there's a million resources, references that I skipped. So that's it.
Cool, thanks, Anne-Sophie. I think there was one question. There's questions about a little bit of discussion about leaving AMA. So so this is from Ken Doyle. What is the legal implication of signing an AMA without documenting capacity? Should the AMA forms indicate that they have been informed, understand, and accept the consequences of leaving? And then on the same note, what if the leaving AMA patient refuses to sign anything?
So there's what the form says, and that's what there's what really happens. So whatever the form says, first, yes, get the AMA. This should be signed. Because it's at least a paper form saying that you stood with the patient and that you explained to them why you think they should stay. What your notes should say is patient deemed capable and understand the consequence of leaving. So your note really should target on that information, on the understanding of the situation. So good wording would be patient was able to repeat what I said and showed clear understanding of my instruction. The case of Dr. Dufour, It was not just the fact that the AMA had not been signed. It's an overall complex, like he messed up on very different levels. So it cannot just be that. If the patient refused to sign the AMA, what I would do, this is a paper. It's just what it is. So what I would do is document really well. And I would say, listen, I'm asking you to sign it, but I'm not gonna code white a patient because he's not signing it. What I'm gonna document, and I'm gonna have the nurse do the same. So you make sure you have a witness, and in your note, you document the encounter very well and explaining that the patient did not sign it, but that's the discussion. And I would really make sure that the nurse does a similar note to corroborate that. So I wouldn't freak out too much if the patient refused to sign it.
I think that's good advice, to have sort of similar stories between yourself and the nurse.
Yeah.
That's definitely useful. No other questions, just some comments saying that very useful, good presentation. Certainly something that we should have at the forefront of our minds when we're writing our notes and taking care. Oh, and one more comment from Monica mentioning a key message by Greg Henry, who spoke at a conference a while ago, was that AMA is not a form, it's a process that involves a discussion with the patient that clearly outlines your recommendations, that they stay, why, what the worst case scenario is if they leave. Being blunt about that, and that you would be happy to reassess them at any time should they change their mind. So yeah, I think that's good advice.
That's the main thing. We have to differentiate what a paper is, and it's just a paper.
All right, well, thank you very much, Anne-Sophie. Thanks to everybody for being present today and all of the other speakers. Just a reminder to the residents that there will be RPC this afternoon, specifically